Now moving on to our second section, that is how to initially assess a patient at the time of injury or at the injury scene. We'll be discussing what is ARM, that is awareness and recognition method, how to manage the patient at the injury scene, and what are the ABC, that is the airway, breathing and circulation, which forms the crux of the ATLS protocol or management of the trauma patients. So how to do the initial management and assessment. That is basically a structured awareness recognition method approach that you ask the patient whether he or she is well organized in time, space, a person recognizes you are the person, anybody or herself or himself, and then you start with the management, that is to start evaluation of the patient with a brief history of what happened, how it happened, and what then to realize what could be the possibly wrong with the patient. Now coming to the awareness of the environment is important. Patient will be able to tell you the pattern of the damage to vehicle. This would actually, if for example this is how it impacted, we probably know that the patient could have some kind of if the patient was only a driver, he or she may be not having a very serious injuries, but if there were two people sitting in front, possibly the one who would be suffering most would be one who was sitting on the side of the driver. If the patient, or was it what happened, was it there was a fire, or was the patient thrown out of the car? If the patient was thrown out of the car, which means there was a very high impact in the problem, and then probably the patient would having multiple injuries as well, along not only with of the trauma but also due to the impact on the after hitting the ground. What was the nature of incidents? That actually tells us what was the speed of the cars which got crashed, and what possibly we can expect from what kind of injuries or what kind of injury patterns the patient would be suffering. Then coming to the particular impaction patterns which are important. Then intrusion of the wreckage, did some kind of a car go into any body part of the patient, or was actually the patient was squeezed in between the wreckage, which if the patient that person was squeezed, that means probably he or she would be suffering a lot of problems. Then bullseye fracture of the windscreen is usually associated with the base of skull fractures. If the patient is having that kind of raccoon or panda eyes, that means there is likelihood of a CNS injury or a base of skull fracture. Then was there any entrapment or fire in it as well? If there was, this means probably the patient is not only having multiple trauma injuries as well, visceral trauma, that is associated burns as well. Now, how to recognize the injury? It is actually based on rapid and systematic questions and examination of the casualty. That is immediate assessment of the airway. You ask the patient to tell you his or her name. That is, you question the patient. If she is elicit a verbal response, that is, patient is able to tell you his or her name, this means the airway is at least intact. Then you look for the loss of consciousness. Is the patient drowsy or not as well? The drowsiness could be due to hypoxia or hypocarbia, and then probably if the patient is non-responding or there could be an airway compromise, then you need to take that patient out of that car crash site. Now coming to the management. The prioritized on the treating is basically the life-threatening injuries first. Then usually include external peripheral hemorrhage is the only exception. Why? Because what happens is, although major arterial bleed of the periphery, we expect that it's going to only cause a limb loss, but actually it doesn't. This may cause a severe hemorrhage, and eventually actually it's a life-threatening emergency. So limbs are not preferred, it's life which is preferred. And the limb loss can be tolerated, but life loss cannot be tolerated. So life-threatening injuries are always the priority rather than the limb-threatening injuries. So the start treatment is actually started with IV cannula. Large bore 18 gauge is usually the first choice. That is, green cannulas are inserted so that patient can be resuscitated with fluids. The option is normosaline or ringer lactate. Ringer is slightly better, but both can be given. Then airway obstruction. If the patient is having a problem with airway, need to restore the airway. Then you give him or her fluids as well by use of IV cannula, oxygen and ventilation. Now this is all is actually pre-hospital management. That is, it follows ABCD, the airway and the cervical spine. As you're restoring the airway, you stabilize the cervical spine either by inline mobilization, attraction method, or by use of cervical collar. Then you move to breathing, you make it sure the patient is getting ventilated and given oxygen, and then in circulation you pass IV line and give fluids. Now, immediate managed phase include basically to assess for the damage to the cervical spine, thoracolumbar spine damage as well. Now, if you look at these things, the important point is that it's not that once the patient is first evaluated from A to Z and then the resuscitation is started. It's actually kind of things go hand in hand. That first, if we have recognized it that there is an airway problem, you correct it, you make it sure the airway obstruction is relieved, and then you move to the breathing. If we recognize there's the breathing problem, you correct the breathing problem and then move to the circulation. That is how the order of priority it is. Along with the airway, you always think of the cervical spine as well. Stabilization could be through the manual inline immobilization, that is putting the arms alongside both the neck of the patient so that the cervical spine injury does not happen, or it could be securement with head blocks and straps. There are actually specialized equipment available in form of head blocks and straps, which can actually, during the mobilization, the neck of the patient is actually not dangling from side to side, rather it's fixed in a certain position, and that is maintained fixed because we need to stop the injury to the cervical spine. Then other option is use of cervical collars. There are again soft collars, there are also hard collars which can be used as well. Long spinal boards are actually used for the transferring of the patient from one area to the another. And why it is actually used? Because long spinal boards are rigid and they keep the spine immobilized so that the spinal injury can be prevented. Now coming to the airway. As I told you, airway and cervical spine are the A of the trauma. They can be actually two methods. This is actually if you see this method, this is actually you're causing the chin lift, and then you can use the thumb of the chin to actually draw it forward, calling as jaw thrust. So jaw thrust and chin lift are actually two maneuvers which can be used to actually secure an airway. This is, as I told you, it's called jaw thrust and chin lift. Then you can use the suction so that if there is any debris, blood, vomit, saliva inside the mouth, that can be cleared. Even sometimes there are broken teeth there, so that can all be taken out, and then we pass and basically oropharyngeal airway. Oropharyngeal airway is the most commonly used, but for example, there is an trauma which is around the jaw. If there for some reason oropharynx is actually injured as well, and one cannot pass an oropharyngeal airway, then we can use a nasopharyngeal airway as well. But usually it's reserved for children only. Most commonly for adults is always the oropharyngeal airway. When we can do this, we can, because airway is actually required in jaw thrust, is required in the casualties like basal skull fractures. So the important is lignocaine gel can be used, as second generation supraglottic devices are also available, but usually they are not readily available as well, and sometimes their use is also cumbersome. So the most common method is actually use of jaw thrust and chin lift, pass an oropharyngeal tube, so that then after suctioning, so that the airway can be secured. Now coming to the airway, once we have done this, but that actually not provides the airway. Once we have done the chin lift, jaw thrust, we have done the finger sweep around the oral cavity so that it can be suctioning of all the materials from inside. Then we have provided the oropharyngeal airway, and from oropharyngeal airway, then we will go for the definitive management of the airway, that is the intubation of the patient. That is important, and intubation is actually done the orotracheal airway. Now coming to this, our endotracheal tube is actually a ETT is passed. Now there is two ways of doing it. If entrapped casualties are difficulty in intubation, for example, there is laryngeal trauma, or the patient is in such case that you cannot pass it, a supraglottic airway cannot be restored, then probably cricothyroidotomy is one of the options which can be done as well to restore the airway. Other option is that if there is no supraglottic trauma and we can go for ETT, then after oropharyngeal airway, the next step is to pass endotracheal tube by rapid sequence anesthetic induction, which is actually the gold standard. You give certain medicines, you relax the patient, relax the muscle, pass the ETT, and then continue ventilation. This actually secures the airway in a trauma. Then important point is sometimes with passing VTT you need a bit of a training in anesthesia, as well as trauma teams should be well trained enough to pass ETT in a trauma patient, because sometimes the patient is actually jittery and as well, and not actually calm, so there is always issue as well. Sometimes the patient is cyanotic, so hypoxic, and actually not aware of the surroundings, so sometimes and there is actually a problem with passing VTT, but one should be most trained enough to pass ETT under any circumstances. Now coming to the after airway and cervical spine, now comes the B, that is the breathing. Adequacy of oxygenation and ventilation is important, and how we can check the adequacy of oxygenation is to assess for lip color, to detect cyanosis, usually in the ear lobe around the lips. If there is bluishness, the probably patient is having a cyanosed area. The other option is use of pulse oximeter. How to check for ventilation is actually assessment of chest expansion, checking breath sounds, using chemical or electric end-tidal carbon dioxide monitoring, and waveform capnography. Although there are multiple modalities which can be used, but the most commonly is actually examination, that is you look, feel and auscultate the chest, and you realize that there is a problem or not. Absence of breath sound means there is actually problem with the breathing. This could be in form of pneumothorax, hemothorax, or it could be in form of emphysema as well. But usually hemothorax or massive hemothorax are one of the very deadly problems, and which has to be dealt, otherwise can lead to higher mortality. Now coming further, continuing with the breathing. If we assess the patient and we know that the patient is probably having a pneumothorax or a hemothorax, then what to do? And we usually perform an open thoracostomy or chest intubation, and that is actually deep pressure tension pneumothorax. Tension pneumothorax is actually a pneumothorax which is on one side, which is actually causing the tracheal deviation towards the other side as well, and best it has to be managed, otherwise it can lead to eventually mortality of the patient. Other options could be an open pneumothorax, which is actually this open or sucking chest wound which can just taking air in and it's not allowing the lungs to expand. That has to be covered with a special dressing, that is actually the gauze is put on the area of the wound and is sealed tight from three sides, so that air cannot go in, but once the patient exhales, the air can come out. So that is how a three-sided dressings can be done to at least convert an open pneumothorax into a closed pneumothorax, and then chest intubation can be done for the treatment of pneumothorax. Coming to the positive pressure ventilation, that is actually simple to it's used actually to convert a simple to tension pneumothorax conversion. For example, if we are already a patient is having a pneumothorax and we are giving a patient positive pressure ventilation, this would actually aggravate the pneumothorax or convert a simple one into a tension pneumothorax. So what we need to understand is we have to do the chest intubation, and then once the chest intubation is done, then we can give ventilation or positive pressure ventilation to the patient. Now from A, we have gone through airway and cervical spine, then to breathing, and now comes the circulation. That is the control of external hemorrhage. If we see the patient's leg is bleeding or arm is bleeding, then what to do with that? That is, first thing is to pack with the hemostatic gauze, compression dressing, compress it as much as can. Please do not probe it with anything, because then that will not only damage, because nerves are lying side to side, and there is always chance that artery is already damaged and you may damage the nerve as well. Then use of tourniquet, although rarely done, but yes, it can be done in case if we are severe hemorrhage. At least tourniquet can be applied for some times, and by the time patient can be shifted to the hospital. Use of tranexamic acid is also a role, because it actually stops bleeding. But the important point is that casualty must be kept warm, because usually with severe hemorrhage there is also associated hypothermia as well. So hypothermia and hemorrhage that can further lead to terrible triad is called acidosis, hypothermia and hypotension. So we make it sure that patient does not goes into this terrible triad of death. Then use of how we can prevent hypothermia is the use of self-heating blankets. Now coming to the circulation. Securing vascular access is by use of a wide bore cannula. As I told you, it's always 18 gauge minimum. Green cannulas, which are usually taken on the peripheral limbs, ideally on the arms, although rarely taken on the limbs as well. But the important point is it must be a peripheral line. It's not always a central line. Then IV fluids are always given in active bleeding. But if the patient is continuously bleeding, then we have to assess whether the patient is responding to your IV fluid administration or not. If the patient is not responding, then we may have to give him blood as well. Prothrombin complex concentrates are also given to stop bleeding. Then if sometimes the problem is actually the hypotension, which may be associated with cardiac tamponade. That is the collection of a blood in the pericardial sac. This is actually not allowing the heart to expand properly and eventually leading to cardiogenic shock. So for that, sometimes we may need a pericardiocentesis. That is, and pulseless electrical activity or asystolic cardiac arrest may be present as well. But then that is, although in the case of cases where sometimes the patient is already on multiple antihypertensive drugs, maybe having an ischemic heart disease, and now he or she is having a trauma as well. So in that cases, we have to make it sure that there is maybe traumatic injury or there may be something wrong with the heart as well. Now coming to extrication and immobilization, how to take the patient out. Spinal protection must be done, and that is by the use of spinal boards. Fractured limbs are to be splinted for the time being, because eventually during the movement we do not want more bone movement because of the fractured fragments, which cause further or aggravate the trauma over the area. Then analgesia may be required so that the patient is pain-free at least during the mobilization. Manual immobilization of cervical spine is done till cervical collar is actually attached to the patient. And then when we are using the cervical collar, it's always a stiff cervical collar so that the cervical spine can be properly immobilized. Then important is clearing of wreckage. If the EMS people feel that joint is dislocated, they can reduce it back and document it, because later on in X-rays that will probably that's important for the documentation, because that means there was a dislocation, for example, and was reduced promptly on the scene. Now if it's a mid-shaft fractures, then we can apply the traction splints and shift the patient towards the hospital. In this section, we have briefly gone through what is the pre-hospital management, what is ARM, that is awareness recognition method, and how to actually ask the patient certain questions so that we can know whether the patient is having compromised airway or not. The crux in the method is let's look for the airway obstruction first, as well as immobilize the cervical spine. Once you've cleared the airway, then you move to the breathing. And if you think the breathing is clear, then you move to the circulation. And if the breathing is not clear, then you have to look out for the cause which is actually hampering the breathing and ventilation of the patient. This could be pneumothorax, hemothorax, or massive hemothorax. And you treat that cause, and then you move to the circulation. And if in circulation there is a massive hemorrhage, we have to control it by applying pressure, apply gauzes. If still giving it a very tight dressing, but if it does not get controlled, tourniquet may be needed as well to control it. Thank you very much. Keep watching sqadia.com.